educational specialist. Amy, you've seen emails from me. Please feel free to reach out with any questions you have concerning the program. I want to give a very special welcome and thank you to your AstraZeneca representative, Dan Ruskin, who assisted with the coordination of this program today. So I'd like to toss it over to you, Dan.
Thanks, Erica. So AstraZeneca, like she said, is a sponsor of the program, and the speaker is presenting on behalf of AstraZeneca. So the questions are invited throughout the presentation, and discuss AZ policies around questions during a virtual program. We could only be on-label questions could be answered during the program, and the off-label questions will be submitted through an AstraZeneca medical information for a response. And at this time, I'd like to introduce Dr. Che. And Dr. Che, actually, he received his medical degree from Seoul National University in South Korea and master's degree in public health and business administration from Johns Hopkins University. He's currently and also completed a residency in internal medicine at Albert Einstein Medical University in Philadelphia and a fellowship in hematology and oncology at Texas MD Anderson. Dr. Che is board certified in internal medicine, medical oncology, and is assistant professor of medicine at Northwestern University, Feinberg School of Medicine. Dr. Che is also participating in 18 ongoing clinical trials and has published over 50 articles in peer-reviewed journals. Dr. Che, I'd like to hand it over to you.
Thank you. Thank you for the kind introduction. So I'm a thoracic medical oncologist and also a phase 1 doctor. I'm a co-director of early phase clinical trials unit here at Lurie Cancer Center at Northwestern. So I've been involved in a lot of biomarker development, targeted therapy development. So it'd be really good for me to present this topic, molecular testing and treatment decisions for the metastatic EGFR mutated non-small cell lung cancer. So this is my disclaimer. This is supported by AZ. It is intended to provide education and information. We're not going to discuss or promote any investigation or approved drugs, and we will not refer to drugs by their brand name or commercial entities. Okay, objectives. First, we're going to discuss the importance of comprehensive biomarker testing. And then we're going to talk about how to evaluate treatment options for patients with EGFR positive metastatic non-small cell lung cancer. We're also going to review data for immuno-oncology therapy in this subgroup of patients. Now, we're seeing more patients being diagnosed with stage 4 non-small cell lung cancer than stage 1 and 2 combined. About 41% patients. And also 1 in 4 patients with stage 3. And we know a lot of them are unresectable, thus requiring systemic therapy. So that's why still lung cancer remains #1 in cancer mortality. Majority of metastatic non-small cell lung cancer adenocarcinomas have potentially actionable mutations. So you'll see KRAS. This is becoming druggable now as we speak. But EGFR 23%, ALK 7.9%, BRAF 2.6%, ROS1 would say 1 to 2%, MET, especially exon 14 skipping mutation, RET fusion, and TRAC 1, 2, 3. Although less than 1%, they are valuable targets. So all these mutations are part of the NCCN recommended panel, and the recommendation is that if you have discovered any of these targets, except for KRAS, which is still in development, you should be considering starting targeted therapy for these before you consider chemo or immunotherapy. So currently, NCCN requires adeno large cell carcinoma or NOS. You need to test for these molecular markers as well as PD-L1. Other ISLAC pathology societies have recommended at least EGFR ALK ROS1, but they're really recommending large complex panel include MET, RAD, BRAF, HER2, and KRAS. And notice that they put KRAS, HER2 here, KRAS here. KRAS at this point does convey information about, that it will, the EGFR TKI would not work when there is KRAS mutation. But like I said, KRAS inhibitors are up and coming in development. So in our practice, we do everything NGS, next generation sequencing, and include everything in one panel, rather than before we used to do one PCR for each mutation, FISH for each fusions. So practice has been changing dramatically. Phenotype does not predict genotype. Test every patient with metastatic non-small cell lung cancer for an EGFR mutation. So we used to think the EGFR mutation would be present in more never smoker, female, Asian, ethnicity, and maybe younger population. But this is debunking the myth. 1 in 3 patients with EGFR mutation are actually smoker or past smokers, and 1 in 3 are men, and really various racial background can still have EGFR mutation. So I guess I don't have to tell you all this, but I think the lesson is we should test it in all phenotypes. And in my practice, like even for squamous, I've seen enough EGFR mutated squamous where you have mixed squamous or adeno that I just run the NGS panel for everybody, and it that includes EGFR, of course. Integrating liquid biopsy testing may help detect more actionable mutations than tissue testing alone in patients with metastatic non-small cell lung cancer. So currently, here, if you use tissue and liquid both at the same time, which I do in my practice, I always do now, tissue testing and liquid biopsy at the same time, it increases detection of actionable mutation by 17% over just doing mutations discovered in tissue. So my experience is about, I would say about 10 to even 30%. One test would find what the other tests have missed. And it's not because one test is superior. Needle might not have gone through a place where there's mutated clone, or you simply might not have a tumor that's shedding enough DNA to have it detected in the blood. So it's biology difference. I don't think technology is that different. I think can't really talk about concordance. You can't really talk about replacing one testing by the other. It's one test complements the other. And if you find a target that's life-changing for patient, even if that's 1% target, they will probably enjoy targeted therapy for a couple of years at least. So it's really giving them time with good quality of life. And then we know if you do biopsy, there's going to be about 28% of quantity not sufficient, and 23% were in people who are unable to get tissue biopsy. 23% were found to have actionable mutation by liquid biopsy testing. So right now, NCCN recommends that repeat biopsy and or plasma testing should be done if initial biopsy is insufficient. Now, if you establish histology, the biomarker testing should include at least these lists that you see here. And if actionable biomarker is present, so the assumption is that you wait for this test to come back, then just blindly start on anything else. So the paradigm, unlike melanoma, non-small cell, is you got a good target, then start the targeted therapy first, and then go to immunotherapy, and you look at the PD-L1 at that time. Do not choose your therapy based on PD-L1 when on other molecular targets are not back. Molecular biomarkers are distinct from immune biomarkers, so you can see they are binary, mutation either present or absent. Immune biomarker, on the other hand, is really a spectrum measured by expression level across a continuum. PD-L1, chemokine, cytokine, B cell, T cell infiltration rates are examples. So tumors with PD-L1 expression may also harbor EGFR mutation. So as you can see, this is sort of like a really nice schema of the distribution. So up to 70% of patients who are EGFR mutation positive also express at least 1% PD-L1. So this is also debunking the myth that EGFR mutated group might be all PD-L1 negative. So again, confirmed patients with metastatic non-small cell cancer are EGFR mutation negative before treating immunotherapy, if appropriate. Variations in test turnaround times may potentially lead to initiation of first-line treatment based on incomplete information. So you can look at the range of turnaround time. EGFR single gene test takes about 3 to 5 days versus NGS panel might take 5 to 20 days. Liquid biopsy testing, EGFR 3 to 5 days. Multi-gene panel, on the other hand, from blood, would take 7 to 9 days. So liquid biopsy in that regard may help. And at my experience, I mean, it doesn't have to be NGS. Some companies will have liquid biopsy panel come back in 48 hours. So there's so many companies out there having different performances. So I think, so in my practice, again, everyone does it differently. I practice in an academic center, and I test NGS from tissue and blood at diagnosis, and at progression, I check another liquid biopsy, and if I can do tissue biopsy again, if patient allows, I do it also. There's small cell lung cancer transformation too, which I can detect by liquid biopsy. Many patients do not receive appropriate first-line therapy because treatment decisions are made without knowing molecular test results. So you see here, treatment decision after EGFR results known, 81%. It's not 100%, that's the key. When EGFR test results were not known before treatment was initiated, 60% of EGFR mutation positive patients did not receive an EGFR TKI at any point during first-line therapy. So I think it's important to know the information. There is no evidence to support treatment with IO, immuno-oncology agents, as first-line therapy in patients with metastatic EGFR mutation-positive non-small cell lung cancer. So here are the 9 most recognized first-line IO trials. They really have excluded patients with treatment-naive metastatic EGFR mutation-positive non-small cell lung cancer. Keynote 024, 042, 189, which is followed which in 0021 cohort G, this led to the pembro doublet chemotherapy regimen. They all excluded EGFR. Same with Nivo Ipi-Atezo trials. The only exception was the pembro phase 2 study, but that was a very small study. Enrollment in phase 2 trial pembro, as you can see here, these are EGFR wild type in blue showed response, and the the rest of it is EGFR positive patients that really didn't show much response. So no response observed in this 10 patients, even though most patients were PD-L1 high, 73% TPS over 50%. One patient was misallocated, and that was the wild type, that one patient that has response. So you can kind of see from the data that EGFR mutated group are not the right group for immunotherapy. First line treatment for metastatic non-small cell lung cancer is based on biomarker test results as recommended by the NCCN. So it's kind of nicely summarized what are those mutations that we need to find to consider for first line targeted therapy. And those are EGFR, ALK, ROS1, BRAF, NTRK, MET, and RET. I think, like I said, you know, the HER2, KRAS, all these things are coming. Not ready for prime time yet. And then you have PD-L1 and these biomarkers negative group that will be considered for chemoimmunocombination options. In metastatic EGFR mutation positive non-small cell lung cancer, testing and knowing all test results is important. Can't not stress enough for optimal first-line treatment. Majority of metastatic non-small cell lung cancer adenocarcinoma, and like I said, I do it for squamous, although obviously the frequency is less, but I do it. But in adeno, you have to do it. There's, I would say 1 in 4 will have actionable mutations, and that will go up as we get KRAS as a target. EGFR mutations can be found approximately a quarter of patients with metastatic non-small cell lung cancer adenocarcinoma. Clinical guidelines recommend comprehensive biomarker testing and diagnosis to help identify appropriate treatment options for each patient. As I do in my practice, I think integrating liquid biopsy testing into clinical practice is extremely important, may help in identifying patients with actionable mutations and decrease turnaround time. Because, you know, I think, like I said, 20-30% you'll get tissue not sufficient, and that you're back to square one. Should I rebiopsy? You know, it's a terrible situation for patients who's just waiting to be started on therapy. EGFR TKIs are the NCCN recommended category 1 first-line therapy in patients with metastatic EGFR mutation positive non-small cell lung cancer. There's no evidence that supports the first-line treatment of metastatic EGFR mutation positive lung cancer with IO therapy. So actually, they put in their guidelines saying that we recommend against the use of first-line IO therapy when oncogene is present. So it's an official recommendation. So this concludes our biomarker talk, and thank you for listening, and I'm happy to answer any questions.
Okay, if anyone has any questions, you can ask them in the chat pod or in the Q&A pod at the bottom. You also have the ability to unmute yourself in the bottom left corner.
다시 뮤트 할게요.
If there are no questions, then Dan, you are free to wrap up. Dr. Che, thank you so much for presenting today.
Thank you.
You bet. Thank you, Dr. Che. Yeah, if you do have any questions, please reach out to myself, Dan Rustin, and I'd be glad to help with any other, later on questions you might have. Dr. Che, thank you for your presentation. Very thorough and up to date with everything. Appreciate it very much. So wish everyone have a great day. And if there are no other questions, thanks for your time.
Thank you. Take care.